This is one of several narrated PowerPoint presentations on my website, audiologyworld.net. Now, tinnitus is a very common problem, and you may be an audiologist listening to this somewhere in the world. For you, my message is very simple. Every audiologist, anywhere in the world, no matter what their clinical setting, and whether they see children or adults, should be prepared to provide services to people who have bothersome tinnitus that's disrupting their quality of life. Now, in most cases, people who have bothersome tinnitus are adults, but there are children who also report tinnitus. It can usually be managed pretty simply and inexpensively. But whether you're an audiologist who primarily provides services to children or adults, you need to be the person to help a patient with tinnitus. Don't rely on otolaryngologists or other physicians to do this, and don't rely on psychologists. We audiologists should be providing tinnitus management as part of our primary care to patients. Now, if you are a person, not an audiologist, but a person who is bothered by tinnitus that somehow found this narrated PowerPoint presentation, my first message for you is you should be hopeful. You should have hope. And I'm going to go through this little PowerPoint presentation. It'll be about a half an hour, as if I were giving this to a group of audiologists or perhaps some doctor of audiology students. But if you're a patient or a prospective patient or a person, a non-audiologist, who is bothered by tinnitus, I encourage you to go ahead and listen to this half-hour presentation, because you will learn a lot, and it might help you as you begin to seek help, professional help for your tinnitus. Keep in mind that every person with tinnitus, no matter how much it bothers them, no matter how much their life is disrupted, can be helped, and almost all patients can reach the point where the tinnitus is no longer a concern to them. It no longer interferes with their life. Now, what I'm going to be presenting today is a very brief overview that I gave as part of a longer session at a recent convention, the 2019 convention of the American Academy of Audiology, which was held in Columbus, Ohio. So that's why you see that banner at the bottom of these slides. But there are other PowerPoint presentations on my website, and there also are articles about tinnitus on my website. So there's both PowerPoint presentations, PDF versions that you will find on this website under presentations, and also you'll find some articles under publications. So I encourage you to seek those out. If you have questions, whether you're an audiologist or you're a non-audiologist who actually is bothered by tinnitus, I encourage you to drop me an email, and you can see my email address here, and you can also find it elsewhere on my website. Let's just begin with a brief definition of tinnitus. Tinnitus is a true perception of sound. In other words, the person with tinnitus really hears the sounds. It's not in their imagination or quote unquote in their head. It's not like this is a hallucination of some type. The person who is hearing tinnitus is really hearing the tinnitus sound, whatever it might be. It might be ringing, it might be a cricket sound, it might be a buzzing. And if you were to use a very sophisticated brain imaging technique called functional magnetic resonance imaging, or functional MRI, you can actually see parts of the brain very active, very metabolic, highly metabolic, that are representing where this tinnitus is in the auditory system in the brain. So this is a real sound, but it's a phantom sound because there's no external stimulus. Usually when we hear a sound, it's because there's a vibration, and that vibration produces a sound like a siren or a train rumbling down the tracks, or an airplane, or somebody's voice, and we hear that external energy, that external stimulus, through our ears and our auditory system. But in this case, the sound is produced in the auditory system. That is, there's activity inside the ear or inside the different pathways in the brain that make us perceive the sound. In other words, we're really hearing the sound, but there's no external sound signal. So it is real, it's not imagined, and it's not just in your head. Now, obviously, you're hearing the sound because your brain is being activated internally by itself, you might say, and therefore, and your brain is in your head. So technically, you are hearing it because of what's in your head, but it's not in your imagination. It's truly a physiological, a real phenomenon. Now, here's another real important point. Tinnitus is a symptom. It's not a disease. People come into my clinic saying, "Can you cure my tinnitus?" You can't cure a symptom. You can treat the underlying problem, the underlying disorder, and that will minimize or eliminate the symptom. So if you have a bad back and you have lower back pain, perhaps with physical therapy, or perhaps with surgery, or perhaps with something else, yoga, for example, you might get to the point where the muscles that are tense that are causing the pain, or the compression of your vertebrae, your discs, or whatever is causing the pain, that problem is corrected, and now you don't have the pain. Same with a toothache. You remove the tooth, or you treat the infection, and now the pain has gone away. You don't treat the pain, you treat the disorder. And the same is true for tinnitus. We can't treat tinnitus as a symptom. We treat tinnitus as a disorder. Now, a lot of people have tinnitus. I have tinnitus. I hear high-pitched ringing. Whenever I'm thinking of tinnitus, I hear it now because I'm talking about tinnitus. It doesn't bother me, and that's the case with many, many people. But when tinnitus is interfering with your day-to-day activities, your ability to concentrate, your sleep, when it's making you feel a little different than you should feel, maybe a little irritated or angry or frustrated, then it's a disorder. Now, I'll come back to this theme over and over. Bothersome tinnitus, that is tinnitus that bothers people, causes some difficulty in their life, maybe mild or it might be very serious difficulty, but in any event, it can always be managed. We can't always correct or remediate the underlying problem. In other words, if you have a hearing loss because you've been around lots of loud noise, we can't restore your ears to their normal state. We can't turn back the clock, but we can get to the point where the tinnitus is no longer a problem for you. So coming back to the back pain, if you lift a heavy box, or if you get involved in some very, very physical activity one day, your back might be re-aggravated temporarily, but then it'll settle down, and basically you almost never have any pain. That's what we can achieve with tinnitus, where you might hear the tinnitus as just any other sound occasionally, but it's not bothering you. So it can always be successfully managed by someone, an audiologist almost always, who knows something about tinnitus. Now, these are what we call psychosocial characteristics of people with tinnitus. Of course, sometimes these same psychosocial characteristics or features also are associated with people who have hearing loss. So this is why tinnitus is a problem for people. You can see why it would bother someone if they're tired or fatigued, they're just not enjoying life like they used to. This may describe you if you're a non-audiologist who has tinnitus, and you're listening to this to learn more about your tinnitus. You might be irritable. I've had spouses, wives, for example, say, Joe, ever since he started complaining about these sounds, he's not himself. He used to be carefree and enjoy life. Now he's a bundle of nerves. He's always yelling at the kids. He doesn't want us around. He's having trouble with interacting with other people at work. This is not normal, and nobody should have to live that way. But tinnitus can create that kind of psychosocial response. Difficulty concentrating. I've worked with a surgeon once who couldn't operate because all they could do is focus on the tinnitus. And that may also involve reading. You try to read, it's quiet, and all you can hear is the sound, and you start focusing on that, and you can't effectively read. Or sleeping. When you have a problem sleeping, you've got a serious problem. So if I have 10 seconds in which to ask a person a question, in order to find out whether their tinnitus is really a serious concern or not, I ask them whether or not they're having trouble sleeping because of their tinnitus. Now, tinnitus doesn't wake you up. When you're sleeping, you're unconscious, and when you're unconscious, you don't hear the tinnitus. But generally what happens is somebody wakes up for some other reason, even just goes into a light sleep, and then they start noticing their tinnitus, and of course they think it woke them up. But when tinnitus interferes with a person's ability to sleep, then you've got a real problem. Sometimes people have actual physiological responses to tinnitus. And some people would call these, these people hypochondriacs or worriers, or maybe just imagining these things. But that's not the case. I mean, tinnitus can give you pain in the, make you feel like you've got pain in the ear, certainly can create headaches. It can make your blood pressure go higher. It can create physiological changes that are associated with worry, with fear, with a threat of some type, of a dangerous threat of some type. So this is why people who have tinnitus that bothers them really need to get help. I've worked with adults, males, a strong adult male coming into the clinic, and they start crying like a baby. And that really bothers people. It bothers their family, it bothers their kids, it bothers everybody around them. But that's another physiological response. The tinnitus sounds are triggering the emotional parts of the brain to force the person or make the person cry. They can't do anything about it. I've had patients with tinnitus, many who are discouraged, but some are actually clinically depressed. And unfortunately, if they go to a psychiatrist or even a psychologist sometimes, or their physician, they're often given medication for the depression, but that's missing the main point. The main point is the tinnitus, which is giving them this sense of loss of all hope. They're depressed, they're discouraged, they're down in the dumps. So the important thing is to treat or manage the actual tinnitus, although sometimes the depression is so severe that actually people don't think they can live much longer. And at that point, acute depression such as that must be treated medically with medication until a person is getting some formal tinnitus help. So anytime your quality of life is reduced, and you can attribute it to the tinnitus, you need to have some professional help. And audiologists that are listening to this, these problems are serious. Patients with tinnitus really, really need to be taken seriously. And you, as an audiologist, not a tinnitus expert, but just as a competent audiologist, licensed competent audiologist, you can almost always help these patients. Now, how common is tinnitus? Well, I'll tell you, it's very common. This is some of the more recent data on prevalence published in 2016 in the JAMA, which is the Journal of the American Medical Association, Otolaryngology Head and Neck Surgery Journal. And it was a huge survey, lots of people, over 75,000. And I'm just going to focus on a couple of the statistics. You can look at the rest. Many people notice tinnitus. Some just occasionally, some almost every day. But the problem that we're discussing here is that 7%, a little over 7%, who describe tinnitus as a big or very big problem. In other words, that's their primary problem. They're generally healthy, but this tinnitus is really, really giving them concern, and it's interrupting their quality of life. And most people don't talk about tinnitus with their physicians, and when they do, most physicians kind of blow it off. Oh, nothing we can do about that. You'll just have to learn to live with it. Don't worry about it. I have tinnitus too. Most physicians don't know anything about tinnitus, or very little, and they don't know what to tell patients. All they need to really do is say, I'm not a tinnitus expert, but I'll tell you what. I know of someone, an audiologist, who can help you, and I'm going to refer you to that person right now. Medication is discussed most often with physicians, which is a shame because medication almost never will help, and it's never a long-term solution to bothersome tinnitus. And ironically, one of the most evidence-based, one of the most effective management options, cognitive behavioral therapy, is almost never discussed. So tinnitus, to sum up, tinnitus is a common problem. At least 1 out of 5 people report it in the United States, and you can see here over 7%. That's a huge number of people find it as a really serious problem in their life, and yet most people aren't getting the help that they need. I don't have time, and it's not really the proper venue for going into all the mechanisms or causes or etiologies and pathophysiology of tinnitus. There are many articles, some good, really good review articles on this topic, and my uh, PDF versions of my PowerPoint presentations on tinnitus, which you'll also find on this website, have more details. Bottom line is almost everyone with tinnitus, I say almost because there are some exceptions, but almost everyone has some problem with their ear, their inner ear, their cochlea. Now that doesn't mean they have a hearing loss. Sometimes it's such a minor problem it doesn't even show up in a simple audiogram hearing test. But almost always, if we use very sophisticated techniques for evaluating a patient's ears, we can detect there's a problem. And that's been proven many times over. When the ears are malfunctioning, even just slightly, they begin to send some faulty signals to the brain. And the brain sometimes hears these faulty signals, hears this imbalance or a disruption in the information it should be getting. It hears it as tinnitus. Now, we know that when the hair cells, the delicate little cells in the cochlea, in the inner ear, when they get damaged, they reduce the amount of energy that's going to go to the auditory system when you hear. But ironically, what happens is some excitatory substances, brain substances called neurotransmitters, are actually released in the nervous system when there's damage to the ear. So it's like the nervous system is trying to compensate for the lower input it's getting from the ear. But the problem is that excitatory activity in the nervous system, which is not there because there's a sound, it's there without any sound, is producing the tinnitus. That's where the tinnitus is represented in the auditory system. And it's been proven in animals, it's been proven in humans. And then over time the brain reorganizes. So now you've got this activity in these brain cells that shouldn't be there because there's no external sound, but it's there almost all the time. It's there in the lower parts of the brain, it's there in the higher parts of the brain, both the brainstem and the auditory cortex. And once the brain reorganizes, that's when a person's hearing tinnitus almost all the time, even though they're not hearing any sound, external sound. It's internal. And that's the person who needs help typically. You might say, oh my gosh, once that happens, nothing can be done. But it's remarkable how quickly we can get the brain reorganized again, or properly organized to no longer be responding or producing the tinnitus. Now, when a person's crying, when they're afraid, when they're upset, when they can't sleep, when they break out in sweats, when they're worried about their tinnitus and they're irritated, then we know that more than just the auditory system, more than just the traditional auditory pathways are involved. So there's two parts of the brain, the limbic system, which controls emotions, and the autonomic nervous system, which has a big role in homeostasis, keeping us on an even keel, keeping our temperature about right, keeping our heart rate about right. We're not too excited, we're not comatose, we're just right. Well, that part of the brain, the autonomic nervous system, also is involved in the fight or flight response. So in other words, there's a danger, we either try to run away or we confront it directly. And that part of the brain, or both those parts, the limbic system and the autonomic nervous system, without a doubt are involved in a person with bothersome tinnitus. Well, the good news about that is if we can disconnect the traditional pathways where you normally hear sound with these secondary regions, these non-traditional areas, we can eliminate the concerns about tinnitus almost instantly. Now, if you're an audiologist, there are clinical practice guidelines that you can follow to evaluate patients with tinnitus, to assess them, and to manage them. Now, the American Academy of Audiology has guidelines. You can see them on the left-hand side of this slide, and you can easily find them online. I was part of the task force that put them together. So you don't have to make things up as you go. We all should follow clinical practice guidelines because they're all based on research evidence. And the other clinical practice guidelines, which are actually more recent, were developed by audiologists and otolaryngologists. The names of the people are listed there, and they were published by the American Academy of Otolaryngology, Head and Neck Surgery. So these are ENT doctors with the help of audiologists. So I would recommend that you get both of those. If you contact me, I'll be happy to send them, but you'll be able to find them online yourself just with a little Google search. You always need to follow clinical practice guidelines with your patients, no matter what kind of services you're provided, and there are guidelines for tinnitus. Okay, now how do you evaluate patients? Well, we're not going to get into this in great detail. We only have about another 10 minutes. So the bottom line is a tinnitus assessment includes a good hearing assessment, the things that most audiologists would do, with a few additional tests. So for example, pure tone audiometry, a simple hearing test, is always part of the assessment. Sometimes it's necessary to evaluate hearing sensitivity for very high-pitched sounds above 8,000 hertz. Most of the time, we audiologists only evaluate sounds from about 250 hertz up to 8,000 because those are important for speech perception, understanding what people are saying. But sometimes people with tinnitus will actually hear the tinnitus at much higher frequencies, and there might be a hearing problem at those higher frequencies. So we should evaluate them if we need to. Tympanometry, which is a measure of how well the eardrum's working, it evaluates the middle ear, is always very useful. We want to rule out middle ear problems, which can make a person hear tinnitus. The tinnitus may be coming from the ear, from the auditory system itself, but if a person's got a problem with their like too much pressure or not enough pressure behind the eardrum, that can make them hear the tinnitus louder, and sometimes they begin to notice it when they have a middle ear problem. So we want to identify those middle ear problems and take care of them right away. Even allergies can create a little imbalance in the middle ear, which then can make a person hear tinnitus. Speech audiometry means the ability, evaluating the ability to repeat words and recognize what people are saying, and of course that should be part of every assessment. Now, if we're evaluating a patient specifically for tinnitus, we need to do two other things. We need to have them complete an inventory, which is usually paper pencil, takes about 5-10 minutes to find out the impact of the tinnitus on their quality of life. So the tinnitus handicap inventory is a 100-item inventory, can be filled out very quickly. Another good one, more recent one, is the tinnitus functional index. So any audiologist can have these in their clinic, and whenever a patient complains primarily of tinnitus, that's their chief complaint, then the patient fills out these forms. Another thing that should be done with all patients who are coming in specifically for tinnitus, in addition to the audiogram and tympanometry and speech audiometry, is distortion product otoacoustic emissions. And I've written a couple books on this topic and numerous articles. Distortion product otoacoustic emissions arise from the hair cells, the outer hair cells in the cochlea, in the inner ear. And if there's a problem with the ear, it will be detected with the DPOAEs. They are the most sensitive measure of the ear. So I would always use those, and I recommend that every audiologist use them in evaluating patients with tinnitus because they're almost always going to reflect or show you what frequencies in the ear are creating the tinnitus. So of all the different auditory tests that you could do with a patient with tinnitus, the distortion product otoacoustic emissions are the most useful. And then the final part of the tinnitus assessment is just measuring the tinnitus itself. What pitch is the tinnitus? What frequency region is it in? How loud is it above the person's threshold? Usually it's just a few decibels. How much sound does it take to cover up the tinnitus, to mask it? And what is the person's threshold for a white noise, a shh, or a broadband noise? White noise and broadband noise is the same thing, because that will be very helpful in determining how much soft, pleasant, environmental sound is just enough to keep the person from really getting bothered by their tinnitus. So I can assess a patient for tinnitus in about 45 minutes. That includes the basic assessment, takes about 30 minutes, and then throw in the tinnitus assessment, that's another 15, 20 minutes. And of course, the inventory that the patient completes, that can be done before you even see the patient. In fact, that can be done at home by the patient or while they're waiting for you to see them in the waiting room. Now, I don't have time to go into all the many different management options. If you're a patient listening to this and you have bothersome tinnitus, be encouraged. There are many evidence-based strategies for helping anyone with tinnitus, and they're all uh, the right one or several in combination always produce benefit. They always reduce the problems you have with tinnitus. For the audiologist listening, um, you may want to evaluate patients with tinnitus. You may refer them to someone else for management, but I would encourage you to start the management process yourself, because most of the things that we audiologists do to help patients with tinnitus can be done by any audiologist. Now, if there's any evidence of a disease or even any suspicion of a disease or pathology involving the ear, maybe a little difference in the thresholds and the audiogram for the two ears, or perhaps some hearing loss for which there's no logical explanation. It's not age related, it's not noise, or if there are symptoms like dizziness or maybe a tinnitus that is pulsatile, it's not consistent, but it kind of pulses, then send the patient to an ear, nose, and throat doctor. Send them to an otologist, an ear specialist, to rule out any possibility of disease or pathology. That's a good thing to do from a medical legal point of view if you're an audiologist, but it's also good for the patient, because when the patient comes back to you for their tinnitus management, you can honestly say to them, you know, all the serious problems have been ruled out by the ear, nose, and throat doctor, so now we can just focus on this sound in your ears. But we don't have to worry about some life-threatening or serious health problem. Now, we always review medications, including over-the-counter OTC substances, because there are many medications that can cause tinnitus or make a person hear tinnitus that they weren't hearing before they took that medication. And as a rule, it's not good to take over-the-counter substances to treat tinnitus, and you shouldn't even take over-the-counter substances of some certain types to be healthier, because some over-the-counter substances can interact with your prescription drugs and cause real serious complications. So I would talk to your audiologist or physician before you take any medication for your tinnitus. In fact, I usually encourage patients don't do it. There's no evidence that these over-the-counter substances help. What am I talking about? Ginkgo, um, different types of vitamins, etc. There's no evidence that they help. And if there are literally hundreds of over-the-counter substances that have been proposed as helpful cures for tinnitus, you can see them advertised, and you get online and you can see all these outlandish claims about their benefits, but they don't work. So stay away from them. That's my advice. But some medications that the patient must take for high blood pressure, for cholesterol, for any number of diseases might actually have tinnitus as a side effect. So it's always good to review medications. And then most of my time with a tinnitus patient is spent on counseling. And counseling can be incredibly effective. In fact, it's the best treatment or management for tinnitus. Most of the time I'm trying to explain the person's test results, tell them what tinnitus is all about, tell them why they're bothered by their tinnitus, because knowledge is power. I've got an article you'll find on my website entitled "An Ounce of Prevention is Worth a Pound of Cure," and it's all about tinnitus counseling. The more my patients know about tinnitus, the more your patients know about tinnitus, or if you're a patient or person with tinnitus, the more you know about tinnitus, the more successful your management will be. So there's plenty of good, accurate information. The clinical practice guidelines I mentioned go into this, and I'm going to show you on the next slide some wonderful little flyers or brochures that are wonderful for people to read who have tinnitus, because it'll help to explain the problem to them. The more you understand a problem, the more readily you can solve that problem. Now, being around soft, pleasant, relaxing sound is always a good idea. So one of my standard recommendations for anyone with tinnitus is to do that. They can have a sound machine on their bedstand next to their bed or in their office. They can use download tinnitus sounds or apps for minimizing tinnitus sounds, mitigating tinnitus sounds from the internet, and use them with their iPod or their smartphone even. If they have problems sleeping, just Google sound pillow, and you find it's very effective. It's very inexpensive. It has a little speaker inside, but it's a very comfortable pillow, and you can program it to produce any kind of sound which will help you sleep. Melatonin is one of the few over-the-counter substances which is proven to help people with tinnitus, and it helps to enhance sleep. So I would routinely recommend melatonin, assuming there's no medical contraindication. Check with your family doctor. But melatonin is very common. It's used as a sleep aid. Many of the treatment pills or treatments that you can buy online really are only melatonin. So you're better off just getting the melatonin very inexpensively, $10 for a bottle, about 100 tablets, very inexpensive. I use melatonin when I travel to totally eliminate jet lag. Just doesn't, I don't get bothered by jet lag even though I travel quite a bit around the world. So melatonin, those are the things that you can do with all patients or all people who have tinnitus, can pretty much help themselves with. Now make sure you first see an audiologist to rule out any medical condition that might have tinnitus as a symptom. But after that, we're just directly managing the tinnitus. Not many people need more than that, but some people with tinnitus, particularly if they have a hearing loss, will benefit from a hearing aid. That's very well known that a hearing aid, which is amplifying or making environmental sounds and sounds that you want to hear louder, will basically interfere with your brain's ability to hear the tinnitus sounds. So anytime you have anybody with any degree of hearing loss who has bothersome tinnitus, the first step is to fit them with a hearing aid. And then cognitive behavioral therapy, as I mentioned, is a very, very evidence-based, but that's usually done by a psychologist. So for the very few patients I've had who just don't respond to my first recommendations, as we've just discussed, or don't get help from the hearing aid, then I often would send them off to a psychologist who has some experience with cognitive behavioral therapy. Okay, I mentioned the brochures. I just want to wrap this up. We're already at 30 minutes. But the American Academy of Audiology, audiology.org, has a nice little brochure, very easy to follow. I would recommend that if you're an audiologist, get some and only dispense them, give them to people with bothersome tinnitus. The otolaryngologists also have a very nice, informative summary of tinnitus for people who have tinnitus and also for audiologists who work with them. And then I would encourage you to get on the website of the American Tinnitus Association, ata.org. They've got all kinds of information for people with tinnitus. Here's the article I mentioned, An Ounce of Prevention's Worth a Pound of Cure. It's right here on this website. It's basically based on the premise knowledge is power. The more knowledge my patients have, the more they're going to be helped as I work with them. So I would encourage you to read this article if you're a patient, or read it if you're an audiologist. I think you'll find it useful. Now, over the years, I've analyzed data for thousands of patients with tinnitus, and many others have, and found that counseling that I was just talking about, explaining tinnitus, helping the person to understand it, resolving any misconceptions the person might have about tinnitus, plus basic sound enrichment, using a sound device, being around soft, pleasant sound all the time, never being in a perfectly quiet place, that helps almost everybody. In fact, most people don't need anything more than that. So here you have these two bar graphs, before and after, pre and post counseling, and a little sound enrichment. And this is 6 months after. So by this time, the person, whatever I've done for them is pretty much permanent. It's not like just the next day or the day after. And you can see on an inventory, such as the Tinnitus Handicap Inventory, they started out with serious problems. Tinnitus was having a major impact on their quality of life. And by the end of it, just one session, about an hour and a half total, that includes the evaluation, the counseling, the tinnitus assessment, they're doing great. And that's very true with many people who have seen patients with tinnitus. It's amazing how effective good counseling can be. Now, there's tremendous amount of information on tinnitus. If you're an audiologist working in the veterans system, Veterans Administration system, tinnitus, progressive tinnitus management developed by Jim Henry and colleagues, it would be a great option for you. But there also is a portion of this for patients, how to manage your own tinnitus. It's a step-by-step workbook. So you can buy these resources online, whether you're a patient or an audiologist, and I strongly recommend them. They're all evidence-based. Now, in recent years, we've become more aware that healthy lifestyle, including a healthy diet, contributes to healthy hearing. And we now know there's research, I don't have time to go into all the details, but research clearly shows that the poorer a person's diet, the worse a person's diet is, the more likely they are to have tinnitus. And the more likely they are to have a hearing loss. So what we eat, to a large extent, determines how we hear. So the more we eat healthily, and we live a healthy lifestyle, we don't smoke, we exercise, the less likely we are to have bothersome tinnitus, and less likely we are to have a hearing loss. So I always talk about this with patients who have bothersome tinnitus. In fact, I talk about it with every patient. Because if I've got a young patient, a 20-year-old adult, for example, 20, 25 years old, if I can get them to eat healthy and to develop a healthy lifestyle, I might be able to prevent them from ever having a hearing loss. So here's just one of the many articles published in the International Journal of Audiology relating the quality of a person's diet and whether they have tinnitus and whether they have a hearing loss. And the research is unequivocal. Healthy living, healthy diet means less problems with tinnitus and less problems with hearing. Smoking's a huge risk factor. So if I have a patient with bothersome tinnitus, I'm going to ask them, do you smoke? And if they say yes, I say the most important thing you can do for your health and for your hearing and to minimize your tinnitus is to somehow stop smoking. Get in a smoking cessation program of some type. It may be that the clinical psychologist who works with them on cognitive behavioral therapy will work on both getting them to stop smoking as well as work on their tinnitus. Okay, hearing aids of just a little open ear, open fit uh, receiver in the canal behind the ear hearing aid will be very beneficial for anyone with a hearing loss who has bothersome tinnitus. And almost every company now makes tinnitus software that will produce some soft sound that will further reduce tinnitus. So I don't talk to patients about hearing aids. I talk to patients about tinnitus devices. I say, do you really want to do something about your tinnitus? And they say, oh yeah, that's why I'm here. I said, well, all right, you need to start using an ear level tinnitus device. And if they say, well, I don't want to use a hearing aid, say, do you want to do something about your tinnitus? Yes. All right, that's what we're doing. We're not fitting you with a hearing aid just to fit you with a hearing aid. We're trying to help you with your tinnitus, and hearing aids or amplification with a tinnitus software is the way to go. Now, let's say a person comes back after a month or 6 weeks and says, you know, I've been using sound enrichment like you told me, and I've really read a little bit about tinnitus in the brochures you gave me, and I've really thought about what you've said, but I'm really still bothered by the tinnitus. I'm really no better. And you administer an inventory, like the tinnitus handicap inventory, and sure enough, they're still struggling. Well, there are more options. So I always tell people at the outset, no matter what happens after this initial visit, we still can help you. Don't get discouraged. There are more extended types of treatment that are evidence-based, and one is tinnitus retraining therapy developed by this fellow here, Pavel Jastrobov. Now, I don't have time to get into it, but basically it addresses sound therapy, that is, helping a person minimize their perception of tinnitus by making sure they're always hearing soft, neutral sounds. And it also involves a lot of counseling to remove the emotional response that a person has to tinnitus, and also the autonomic or fearful response. So the whole goal of this therapy, or I should say the counseling, is to get to tinnitus to be just another sound. Because once the brain starts hearing tinnitus just as any other sound, it will habituate. It'll adjust to it. It'll stop hearing it. Whether you live near a set of train tracks, or there's traffic noise, or you have a grandfather clock that's ticking, after a while, noise that carries no meaning, that's not a danger signal, that's not meaningful in any way, you'll stop hearing it. It's a natural phenomenon called habituation, and that's the fundamental concept behind tinnitus retraining therapy, and it does work. If a patient really is struggling with the tinnitus and these first levels of treatment, sound enrichment, counseling, directive counseling, maybe melatonin, if it's not having a real significant impact on quality of life, then the next step is cognitive behavioral therapy, which definitely works. And there's plenty of information. There are even some self-help books and videos on cognitive behavioral therapy. All right, it's about 39 minutes, and we're at the end of the slideshow. I hope this has been useful. I'm going to conclude by saying that everyone with tinnitus can be helped. You may say, how can he make that statement? It's based on the research that's been published over the last 25 years. It's true. Everybody can be helped. And most people can get to the point where the tinnitus is no longer an issue at all. They might not even hear it. And the second point I want to make in conclusion is that audiologists should be the ones, the professionals, who take care of these patients. We know the auditory system better than anyone else, and we have the tools and the knowledge to help people with tinnitus. Now, we may need the help or support of an otolaryngologist or a neurologist or perhaps a psychiatrist or even a psychologist, but in most cases, we're going to be responsible for managing a person with bothersome tinnitus. Now, if you're a patient and you want more information, there's plenty of information on the internet, or go online and try to find an audiologist. You can almost always do it with a Google search, who cites tinnitus as one of their specialty areas. The American Academy of Audiology actually has a tinnitus specialty certification. So you can usually find people on the internet who clearly have more than the average amount of training and knowledge about tinnitus, and seek their help. And if you have problems finding someone, just contact me via email. Thanks a lot for listening. Hope this has been useful, and check out the rest of my website.